Anyone with lungs can develop breathing conditions and diseases. Add sleep apnea to the mix and you have significant pulmonary problems. Lung disease and sleep disorders tonight on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. We seldom think about our breathing until it's somehow compromised by a cold, the flu, allergies, or worse. First though, let's take a look at this week's Prairie Doc quiz question. Chronic obstructive pulmonary disease, COPD, emphysema, and chronic bronchitis are all A, restrictive airway disease, B, obstructive airway disease. It's a subtle but important difference. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. We answer your questions about lung disease and sleep disorders all through the show, though, as they are called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight are Dr. Jeff Boyle, MD and PhD, a sleep neurologist with Avera Medical Group Neurology, Sioux Falls, and Dr. Travis Hanson, a pulmonologist, specialist in critical care medicine with Avera Medical Group Pulmonology and sleep medicine in Sioux Falls. Thank you, gentlemen, for joining us.
Yep.
So, and I'm going to say this, we can answer questions about respiratory diseases, all kinds of lung diseases, inhaling problems, whatever it might be with the lung, or critical care. With Travis and with Jeff, we can answer any neurology question that you have, but we can also concentrate on sleep apnea tonight. You have sleep apnea questions, bring them to us. So let's define sleep apnea. We'll start with you, Jeff, and that's interesting. Most of the time I've had sleep apnea specialists, they're pulmonologists, but you're a neurologist with an interest in this. Tell us a little bit about how that happened.
Well, I've always found personal interest in sleep. It's it's funny that we have to do it at all, and so in college I really tried to restrict my sleep, and it just didn't work out. I didn't get the grades that I felt I should have gotten, but I was studying all the time, and so after that I went into residency and improved my sleep quality. And
that's funny because my sleep quality went downhill during my residency. But
we have to pay attention to that.
Yeah, that's important.
And feel better. So then in residency I really focused on brain diseases and got a lot of training in many aspects of that. And sleep was something I could have gone into, and I didn't have interest. But I liked how sleep studies were run, and you could really study a person in every aspect of their sleep in a sleep study. And so I got training to read those studies, and it's been a fun experience ever since.
And we'll have to talk about the neurologic aspect of sleep. The different levels of sleep, the kinds of sleep, dreaming, and what the neurologists think about it. But the pulmonologist sees it in a different way.
Yeah.
Let's talk about your perspective or your definition of sleep apnea.
So I like to call it obstructive sleep apnea when I see it, and it's a sleep disordered breathing, and so it's to bring it back to breathing in the lungs, and so and that when people with sleep apnea are sleeping, they're not breathing normally, and thinking about it that way, and so there is a large neurologic component to this, and especially with the central sleep apneas and things, but. The neurologic aspect of sleep is actually much more interesting, and so especially with certain narcolepsy and the fainting goats and things like that. That's pretty.
Fainting goats?
Yeah, where they can you scare them and they fall over.
Oh, I've seen that.
Yeah, so that's more interesting than the sleep disorder breathing type of process.
So humans do that and not just goats.
Yep, narcolepsy.
Yeah.
in narcolepsy.
Yeah, yeah.
So,
So-
you can scare somebody, or they can laugh really suddenly and they collapse
Pass
to the
out.
ground. Yep.
So that-
Similar biochemistry there.
Yeah.
But many pulmonologists have a interest and a expertise in sleep apnea.
Yeah, and it fits in nicely because of the breathing issues and the respiratory devices used to treat it. We use them for other, diseases. So COPD, acute respiratory failure, things like that. Very similar to how we treat sleep apnea. So it fits in nicely, I think, with our training and our sort of our wheelhouse.
So people talk about obstructive sleep apnea is like 80% and 20% is central, which is the drive to breathe is not so. Obstructive is there's airway blocking. And that's the big snorers that get apneic in the night, and the central is a kind of a quiet one that people don't even realize they have oftentimes.
I had a patient today say that, or the wife of the patient said, they're running a marathon. They breathe very heavily and then they're quiet. And then they breathe very heavily and then they're quiet. And we can see this in neurologic disease such as dementia and Parkinson's disease. And so that's where we kind of have a good role for that.
Right. So many people have mild sleep apnea, which is one level, but when you have moderate to severe, we know that that's life-threatening. Explain that a little bit, Travis.
Well, I think, for mild sleep apnea, it might not be as big of a deal, but if there's other medical problems, then we still want to treat it,
Right.
And so with moderate to severe, we would want to treat it probably without a lot of those other medical problems just because it poses a danger in itself. Good quality sleep is important for every organ system in the body. It just is vital to how we function. And so when you don't have that, anything can go wrong. And so people can't focus as well. There's a lot of brain issues. Chronic pain is harder to treat. Maybe an increased risk for clots, harder to control abnormal heart rhythms, more urinating at night. A lot of things just get thrown out of whack. And so it's definitely in moderate and above, we always want to treat. And like we talked about earlier, the treatment's very safe. And so if you worry about the risk and benefits, like we always have to do with everything that we prescribe, it's definitely something that every doctor will recommend because of the safety profile. Very, very safe. So.
If you can treat somebody without having to use a drug that can mess up things internally and have side effects, I mean, this is no side effect except it's hard to get people to use it.
Exactly.
But let's talk a little bit more about the dangers of sleep apnea, whether it be driven by a brain that doesn't tell you to breathe or by obstruction. You talked about abnormal rhythms. What about Alzheimer's? I've heard that there is some tying into the dementia issue.
Yep. I think dementia is, there's a lot of things that can factor in, whether it's family history or exposure to substances like alcohol chronically, but sleep seems to be something where we're looking more and more into as far as a cause for dementia. So recently, with some of these proteins that are involved in dementia, with tau and amyloid beta, these proteins accumulate in the brain. And it's almost like the brain forgets how to take the garbage out. And so a study was done, I think about 10 or 15 years ago maybe, looking at how the brain drains and gets rid of
the garbage.
The garbage,
How
takes
do
out the
they
garbage.
get that garbage out of there?
Happens at night in sleep. And certainly it looks like there's more of these proteins accumulating, and I think more has to be done to see if that actually leads to dementia. But the glymphatic system, or glial lymphatic system is how they put these words together, may be involved in that. So it's being heavily studied, and certainly we'll get eventually to treatment based on that. But certainly treating sleep apnea is going to probably make a person feel better in multiple ways.
And maybe just prevent Alzheimer's disease.
I hope so. I hope we can.
We can prove that. I do know the Australian study took people 30 to 60 years of age, and they followed them 13 years, and they monitored whether they had sleep apnea or not, or mild or moderate to severe. And the people who had none or mild had a 6% death rate over that 13 years of period of time. They kind of thought that was about right. That's what usually, you know, car accidents and cancer and heart attacks and so on and so forth. And the people who had sleep apnea had 35% or 30% death rate. Five-fold difference in death rate of the people who had moderate to severe sleep apnea. So if you had a treatment that would reduce that, and we've proven that Cpap does if you actually wear the darn thing, why wouldn't you do it? But still, the studies show like 30% will wear the Cpap and 70% will not. What do you think about that, Travis? I mean, that's your bane of your life, isn't it?
It's tough. It's an everyday struggle, you know, to encourage people to wear it. And I tell them the same thing. I say it's safe, you know, work on it. The good news is there's some people that they feel so much better even the next day sometimes, that they keep you going and keep you trying, you know. And so, you know, it's nice to see people say, I didn't know I felt so bad until now I feel, you know, this
so
good.
much better.
And so, but yeah, you just got to keep trying, because at the end of the day, it's a very, very safe and highly effective treatment, and it can prevent a lot of problems down the road, especially if you're having that happen every night for 20, 30, 40 years. It's putting a lot of stress on your body, you know, and it'll catch up at some point, one way or another.
So, and what I have read is that mild or mild to moderate sleep apnea can be treated by epiglottomies and throat surgeries and devices that throw your jaw forward, or even exercises, certain exercises to strengthen the tongue and the muscles of the throat, so that they don't just kind of fall in the way when you sleep. But that when it comes to moderate to severe, it's CPAP.
Yeah.
Am I right in that?
Yeah.
I mean, and so people who get moderate to severe and they can't do it, and they go, well, I want to use one of these other things. Well, the other things isn't enough.
Yeah. I think, and you can talk on this too. My thing is, if you're going to have a big surgery, that's not, then we talk about risk benefits, and you're going to have a surgery, that's a little different than a CPAP. There are other things, like you said, exercises. There's, you know, nerve stimulators to stimulate the nerve to try to keep that tension on in the neck region. Even snoring chin straps you can buy online for $8. One small study showed that can treat mild sleep apnea. Position is important. If you only have sleep apnea on your back, sleep positional therapy can help. But
sew a tennis ball in the back of your pajamas, so you roll on your back and you go, oh, I got to go all the way around.
Yep.
So all those things, you know, can help. A dental appliance, those are expensive though. You know, have a dentist make you a mouthpiece, but I think those are all fine alternatives. But in my experience, and you can comment on this too, most people end up needing a CPAP regardless. And so I'm pretty hesitant on a big surgery, because when I know there's a safer, more effective alternative, it's hard to recommend, yes, go have your jaw, you know, extended 2 inches. You know, that's a big deal to me. And so I don't know many people that would want to do that when there's a safe alternative there.
Well, and I don't know about the implanted device. Do you Inspire or whatever?
Yeah, it's relatively new. I think 5 or 10 years it's been out. And I've sent a few patients. The University of Minnesota can implant the device. It's for certain select patients that are CPAP intolerant, but
it stimulates you to take a breath without waking you up.
It reads if you're breathing, and then it stimulates the tongue. It goes up into the base of the tongue, which is kind of underneath here, and then as you breathe, it'll kind of electrocute the tongue just a little bit, just a little buzz, and the tongue will move forward. And you can titrate this, or you can move the dial on how much the tongue moves even.
Oh, wow.
Yep. And you know, this is one of these alternative therapies. But what we have is, you know, it's a sleep study that we read, And the first part of the night, the person's having terrible sleep apnea, up and down. Their oxygen's going to 50% or 75%.
And it shouldn't go below 89%.
No, it really, I mean, 93 for a really healthy person should be kind of
as low as it's going to go.
Yep. But I mean, you have these people that are just struggling, and with just a little bit of pressure, sometimes, just a little bit of pressure on that Cpap, they're up at 95% all night. It's like magic how this little bit of pressure can do that. And people, say, well, I'm going to have this big surgery. It says, well, I saw you in your sleep study. You looked so good. If you can just get this machine figured out.
Yeah.
Get the mask working.
Now, and I have heard that a lot of that's dependent on the operator who fits the mask, who sets the machine, and that if it isn't working with that particular company, try another one. I mean, have you heard that, or do you believe that's the case? I mean, you need someone who has the patience to work with you, to keep trying and tell you. And sometimes people need not just Cpap, they need the stimulant to breathe. So they need BiPAP, which is what?
Bi-level or two-level pressure therapy. So they breathe in, and the pressure's higher, so they feel like they can push more air in, and then they're not pushing as hard when they exhale, and the pressure's a little bit lower, but not zero or not atmospheric pressure. So it still keeps the airway open, but they get that extra boost breathing in.
Yeah, it's sort of like whether they're on a respirator, only they have it from the face mask, right?
Yeah.
It breathes for them.
And during the titration portion of the sleep study, if a CPAP's not able to correct it, or if in some cases they can't tolerate that CPAP pressure, we can switch to a BiPAP. Sometimes that's better tolerated. It takes that work of breathing away a little bit, so you don't have to try as hard. If people qualify for it, that's another option other than a CPAP.
So I read, before we go to the next Roland, I read about using the jaw thrust device plus the Cpap, and the device makes the Cpap work so much easier. You've obviously you guys have experienced that. And the other thing I read about was double reed oboe or bassoon players seem to be doing the exercises that we talked about earlier that strengthens the tongue and the epiglottis and everything. Not the brass players, not the trumpet player, not the bass player, but the double, or even the didgeridoo. So isn't that interesting?
Yeah, it is. That's cool.
Breathing problems can sometimes take years to progress. Others happen in the time it takes to inhale.
It was a really hot July day, and I went into a manure pit to unplug a bulky pump. And I got into the pit, and I was starting to unplug the pump when suddenly I began to feel really weird. And I thought to myself, well, it must be that gas that I've heard of. And so I began to exit the pit, and I was nearly out of it when everything just faded to black like at the end of an old movie. And I'd been overcome by hydrogen sulfide gas, which is one of the most deadliest gases known to man. And my parents discovered me floating in the manure a little bit later, and they summoned help, and then I was taken to a local hospital where they basically said, he's probably going to die. But thank goodness my wife kept her wits about her, and she insisted that I be taken to Sioux Valley Hospital in Sioux Falls, and they worked on me down there and said that, well, if he lives through the next 7 days after that, we'll give him a 50-50 chance. And I was in the hospital for about a week, and my wife hardly left my side the whole time. And she came in to see me. I was in intensive care, and I was mouthing to her, I can't breathe, I can't breathe. And so she summoned the doctors, and they looked at me and they said, well, here's what we think is happening. How when your knee gets banged, it'll swell. Well, Jerry's lungs have been injured and they're swelling, and there's likely nothing we can do. You better call the family. This is it. So my wife asked that they call Mayo Clinic to see if there was something else that could be done there. And so the doctors called Mayo Clinic, and they said, well, he wouldn't last the flight to Mayo Clinic, so why don't you try to go down with an endoscope? And then they discovered that there were blood clots that were plugging some of my bronchial tubes, and they pulled them out, and then I was able to breathe much better. The short story is there was a slow but steady progression, and after 5 weeks or so I was able to walk out of the hospital unassisted. And I went back about 6 weeks after the accident, after I got out of the hospital, and underwent a bunch of extensive and expensive tests to check my pulmonary capacity, and it was within the range of normal already at that time. So I was lucky to get out of that with very little other than a few scars, and but I was so anoxic at one point that my brain had begun to die, and I kind of lost my peripheral vision. Some of the cells in my vision center began to die, so I was that close to death. The isolation is a factor, and then the fact that farmers and ranchers are their own boss, you know, with the exception, of course, their wives. So nobody is telling you, well, you should get that cough looked at, or, you know, that's kind of an ugly cut you got there, you should maybe get that looked at. And, you know, we tend to just muscle through it if we can, and probably wait too long to get treatment for something. We live and work in a very dangerous environment. There are things waiting to kill us all over the place. You know, cattle are dangerous, the machinery obviously is dangerous, and then invisible things like gas. Think and then think again, and be safe. Have somebody else around, and thank goodness we have cell phones and stuff now. We didn't have cell phones back then, so we had to summon help the old-fashioned way. But don't put yourself in a situation where you may regret what happened. You know, we all know people that are missing limbs or have died because of their haste.
Well, we thank Jerry Nelson. You know, he's a humorist that writes for newspapers, county agent guy, just a great guy, a wonderful man, and his brain functions returned, and we thank him for that story. This is your program. Your questions are key to the direction of our discussion. Call in your questions to 1-888-376-6225, or send us an email to ask@prairiedoc.org. And we've got questions. Belle Fouche woman has sleep apnea and will quickly zonk out without warning on the couch for 5 to 7 hours without her Cpap machine. Is this normal to have the tiredness come on so quickly and suddenly?
I think it can be. You know, if the sleep apnea is severe and or undertreated, I mean, the body will demand sleep. And it will get it no matter what. And so it can come on rather rapidly, and you have to anticipate, you know, situations that you're going to fall asleep at. And if you're going to fall asleep, just put the mask on and watch Jeopardy, and you'll fall asleep, you know, and you'll have it on, and you'll be safe because you're on the CPAP.
Yeah, so. That's great. One viewer has asthma and COPD. What is the best treatment for this?
Well, it depends. So
asthma and COPD.
Yeah, and so we would call that asthma-COPD overlap syndrome. And
could define the difference.
So asthma is an inflammatory lung disease, as they both are. That's usually going to be from more of the type 2 inflammatory pathway, allergies, things like that. We see a blood cell called eosinophils that tend to be high with that. There are other subtypes of asthma as well.
And it can reverse with a bronchodilator, just like that.
Yep, and that we usually want to start with inhaled steroids for the long-term treatment. COPD usually is from exposures, most commonly smoking, but can be from occupational exposures, other things. That's more neutrophils instead of the eosinophils, still inflammatory. But with that one, we don't want to do the steroids up front right away because of some risk for increased pneumonia in those patients, and we'll try other drugs, bronchodilators first, and maybe add a steroid depending on certain things that we can see on the breathing test or on some labs. And
atropine-like medication.
Yep, those anticholinergics now are probably the best first line for mild to moderate COPD. And if people are getting worse or having a lot of symptoms, then we'll add a long-acting bronchodilator. There's a beta agonist like albuterol, but it lasts a little longer. Add that, and then third line, if we go triple therapy, would be the steroid, and that really depends on how things are going. And that's kind of changed over the last year or two, the order of the meds. So.
You know, it used to be asthma that was an inflammatory thing that would reverse with albuterol to prove it. Mm-hmm. And then it would be emphysema, which is a type of a loss of elasticity. Mm-hmm. We'd use atropine. And then there was chronic bronchitis, which you'd kind of use the steroid and the bronchodilator combined, and sometimes antibiotics and so on and so forth. But we don't say emphysema anymore. It's generally saying COPD, right?
Yeah, and so, you know, it gets pretty tough because the definition of COPD includes chronic bronchitis, emphysema, asthma, things like that, and that's defined on your breathing test. So there's airflow obstruction when you breathe out. That means there's obstructive lung disease. Now you can have emphysema, if we see on your CAT scan, there's little holes in the lungs from smoking, but maybe not have the COPD, so there's no obstruction going on. Same with chronic bronchitis, we diagnose that clinically with chronic productive cough, you know, for lasting for a certain amount of period over 2 years. And they could have chronic bronchitis without obstruction as well. And then your asthmatics. And then there's, you know, sort of overlapping circles where you could have all three of them, I guess, you know. And so.
What's the value of people taking their inhalers?
Well, that's the thing. So in all of those, symptoms are important. So we want to control symptoms and improve quality of life. But we know that if people have these lung diseases and they don't, they don't control that, chronic inflammation, irritation can lead to a decline and permanent damage that then will become irreversible.
People with asthma, are they the ones that turn into emphysema?
No, not really. So chronic, we do see people with asthma who develop COPD in more of a fixed obstruction that no longer reverses after years of that inflammation. Their imaging and things usually doesn't turn into emphysema, but more of just a fixed obstruction, similar to a smoker, you know, if it's not treated.
Okay. Yankton Man has diagnosed with emphysema and heard that stem cell therapy might help. Is that possible, or what other cures are there for emphysema? Have you heard of stem cell therapy?
Yeah, and you know, it's not mainstream yet. I do have some patients who went to actually Chicago to have this done. One part of a study and one paid money, and so it unfortunately didn't work for either of them. We don't have conclusive data that it helps, and so right now it's not considered standard of care. I don't think it's something that would yet be covered by insurance, but if it's part of a research protocol, it might help. There may be an increased risk for cancer with those, though, is one concern. And so end-stage emphysema or end-stage COPD, when all other options are exhausted, then it's still lung transplant would be the
One woman asks about tremor. So there are different kinds of tremor. How would you define them, and can anything be done for familial tremor?
Sure. So there are multiple kinds of tremor. Everybody has a little bit of tremor. If you hold a sheet of paper, a little bit of tremor will come out on
Almost
anybody.
everybody.
Almost everybody.
Particularly when you're older and you're tired and you just
anxious.
And you just exercise.
I'm pretty steady.
Oh, are
Well,
you?
maybe you should have gone into surgery.
Maybe you
Talk about surgery.
I break things. That wouldn't be a good surgeon.
So a rest tremor can just be when somebody isn't paying attention, and that's a little bit more concerning than other forms of tremor because it can be suggestive of Parkinson's disease or Parkinsonism.
That's usually one-sided, isn't it? Not always.
It can be very
And it's
one-sided.
at rest.
And it's at rest. So people will be watching television or not really thinking about their hand, and it will be going, and then as soon as they go to pick up a cup, boy, they're pretty steady, you know, especially at first. And then familial tremor, like the viewer asks about, is more of a tremor that does happen when somebody holds a cup.
I mean, they have trouble eating soup.
And eating soup, yep. And so they have to make those.
So what do you do for that?
There's lots of different things. Actually, tremor is relatively easy to treat with medications, and then as people have progression, because some of this tremor gets worse, then we can do deep brain stimulators. We have a great program at Avera. Once symptoms are just uncontrollable with medications, a stimulator can be placed in the tremor, part of where the tremor is generated, and we kind of stun that area of the brain with a little bit of current, and the tremor, like magic, just stops.
But that's not the tremor from Parkinson's.
And that's not the tremor from Parkinson's.
And the benign familial tremor, I like the word benign, it is not associated with dementia. It's not associated with any neurologic. You don't lose your brain. There's no dementia that goes with it, right?
Correct.
It's just a tremor.
Just a family tremor. It's usually, the Boyle tremor or the Smith tremor. Usually the families know about it as it's going down, and they know more about it. But it's not always like that. It can come through in different strengths in different families.
All right. I'm on trial for multiple myeloma treatment. Part of the treatment is taking dexamethasone once a week. On that night I take the medicine, I rarely sleep. Do you have suggestions for increasing sleep or better sleep quality on that night? I would potentially be on this medicine for another year. I can speak to this. As I was getting chemotherapy, they would give me steroids to help me with the nausea and all of the complications of the chemotherapy, and the side effect from the steroid was worse than any of the side effect from the chemo. And I had them cut it in half, I had them cut it in a quarter, and then I finally had them eliminate it, and then I could sleep. But I did use melatonin with help. Let's talk about sleep medication because it's important. I have often said the benzodiazepine sleeping medications, you have to increase the doses for them to continue to work, and then you have withdrawal when you stop them so you can't sleep for weeks or for a week, and you can seize. I try not to use the benzos, and I use trazodone and I use melatonin and those kinds of medication, not the benzos. What's your take on that, you guys?
I agree. Yeah.
Yeah. With benzodiazepines, it's a kind of a messy drug. It can help with anxiety, it can help with sleep, it can help with alcohol withdrawal and all these things. But it's very powerful, but very messy. So there's a lot of side effects we worry about. So
dementia being artificial chronic dementia that brought on by the benzos.
Yep. So I tend to avoid them as well, if possible. There are certain indications that I think they are needed in, but generally speaking, I think judicious use of sleep aids is important. I think you don't have as much of that rebound insomnia when you stop them. If you limit it to 2 days per week or 2 nights per week.
Yeah.
So.
Benzo twice a week, but it's so the medicines are almost like 2 shots of Jack Daniels. Suddenly it's every night, and then you can't get off of them.
Yeah. And they might help you fall asleep, but it's not always a good quality sleep. So the most restful part of sleep will be disrupted by the benzos. And so I like melatonin. I think for this viewer, trying to take the steroid as early in the day as possible, maybe that might help. Decreasing the dose like you did, or doing melatonin. The key with melatonin is you have to take it early, after dinner maybe, or early evening. Don't wait right before you go to bed, because then it's too late for it to really help. So.
And if she takes it once a week and she used a benzodiazepine that one night or the next night only, that would be acceptable, I would think.
Yeah.
Snoring has been the target of humor from the Three Stooges to the Big Bang Theory. But there is a dark, serious side to this comical tradition.
10 or 12 years ago, Dr. Holm had me take a sleep test. And at that time, it was negative. I would wake myself up snoring somewhat, but to the point that I've been famous for my snoring. Rick even recorded it on a sailing trip one time. But I redid a test at the behest of my internist in June of last year, and I found that I had mild to moderate sleep apnea. And they recommended getting a Cpap machine. Apparently the tongue, or the back of the tongue, drops back into the throat and blocks off your air passage, and consequently that'll wake you up. And the one thing that they're concerned with is the oxygen level in your blood. And mine has always been pretty normal. In fact, during the first test that I had, it was quite high. But once again, the doctors and the sleep specialists will make that determination. But that lower oxygen level during the night can be harmful too in the long run. People that have apnea or sleep problems, they go to bed and they get interrupted sleep all night, and they wake up in the morning and start the day, but you're always tired. You always feel you have to nap, and of course I don't have that anymore. Well, it creates artificial air pressure for your air passage, so you don't have the apnea, and you keep breathing normally through the night, which gives a person like myself a good night's sleep. In fact, the first night that I used it, I was totally amazed. I slept for 7 solid hours, something I haven't done in 25 years. There's no noise, and you don't notice it, obviously, when you're sleeping very well. You're into that REM sleep. I would highly recommend it. I've recommended it to friends who have had sleep studies and had a Cpap recommended, but they've been reticent to take that step to try it. Obviously, there's the machine and a reservoir to provide humidity for your air at night. But the mask itself is hooked to a hose, and if I may demonstrate, okay, let me put this on. And then there's 2 magnets that snap like that. Now obviously it isn't for conversation or recording, and it looks odd, but you honestly get used to it.
That was just great with Lee. Loved it. Thank you, Lee, for that. Really, a question that follows is it just echoes what Lee made the point. A Flandreau man comments, anyone that does not use CPAP machine is only cheating themselves. Quality of life is amazing. It has changed my life for better. It is a shame 70% of the people don't use it. Wasn't that a wonderful comment? And the truth is that if you're in that 70% whose CPAP machine is sleeping under your bed, think about the fact that it will increase the quality of your life and the length of your life and reduce your death rate by 5 times over the next 13 years. So, am I saying the truth? Are you going to agree with that?
Oh, yeah.
Yep, absolutely.
A Brookings woman asked to talk about nocturnal hypoxia, where individuals' oxygen stats drop at night, and was wondering about the effects to the body and the brain.
Sure. So hypoxia or hypoventilation is a little bit different than obstructive sleep apnea. The person just doesn't take deep breaths, or there's some lung problem that just prevents absorption of the oxygen and exchange of carbon dioxide. So the oxygen's low, and it still needs positive airway pressure therapy oftentimes, and that'll help with that. But making sure that a good lung exam is performed and I think is key to that, and then really just following with your doctor to see how treatment is going is really important to do that.
Sometimes just oxygen helps certain people, right? I mean, with this kind of a thing, just oxygen.
Yeah. It can help, and I think one of the dangers of low oxygen at night, there's a few. I think the brain seems to be a little more sensitive to lower oxygen than some of the other organs, but also in the chest, so your pulmonary artery, which your right heart pumps blood to your lungs through the pulmonary artery, with low oxygen that will tighten up and the pressure goes up. Well, the right heart has a hard time pumping against that higher pressure, and over time it's not like the left heart that can get bigger and stronger. It can wear out a little bit. So and certain people, especially if they have pulmonary hypertension, we want to prevent any low oxygen at night, because it can definitely make that worse. So.
A Sioux Falls woman asks, is excessive drooling, saliva a neurologic issue, or could it also be anxiety?
Well,
that's interesting. That's a good question.
That is an interesting question. Yeah. Certainly having a dry mouth at night, if this is drooling at night, I mean, I think that'll lead to excessive salivation, and the mouth is trying to moisten itself, but oftentimes people will sleep with their mouth open, and that will lead to more drooling.
Yeah. I think in the geriatric literature, we know that the majority of saliva problems is dryness, but there's some people who have excessive saliva as they get older. No big deal, just thank your lucky stars. Sometimes it's the dentures don't match. So just talk to your dentist about it. But you're lucky, because people suffer from not enough saliva, and that's a big problem. Another Sioux Falls woman says, I'm a real poor sleeper. Does that mean I have sleep apnea?
Could. Poor sleep is a sign, could be a sign of sleep apnea. Doesn't necessarily mean that's what it is, but it's definitely in the differential.
25% of people over 70 who may not have symptoms of anything else, or at least somewhere in that range, can have sleep apnea. Yeah. And so I'd push your primary care doctor to look at doing a screening test.
If there's sleep problems, that's the first thing you want to rule out in most cases.
Right. It's so treatable, and the response can be so excellent. So it's definitely worth considering.
Save your life. Philip Mann says they have come out with a cleaner for CPAP machines that is supposed to disinfect them. What are the doctor's take on these CPAP cleaners, and is there a certain type that is better than others, and are they necessary?
They're not necessary because you can clean it on your own. Now, it's a convenience thing. And so, if you...
Soap and water, clean it, not worry about it.
Yeah, and so, but I think it is convenient, and maybe some people like it, the convenience part of it.
It's not necessary.
I like things that are done for me, and if I don't have that done,
then it
I
might get pretty
not
grungy.
Do it.
Yeah.
It may get grungy, and that grunginess can lead to problems, and so
infection.
If you're not washing it, it may be worthwhile thinking about getting it.
Have you? Yep. There's another way, honey. Would you clean my CPAP? Sorry, that was a.
No, we do say that CPAP's safe, but if it gets too dirty, then it can actually cause harm. So that if it's between not cleaning it and getting a cleaner, you gotta get a cleaner.
And when I said honey, it could have been the husband.
And
it could have been the wife. We're not talking sexist. We're spousal help.
Yep, we all need help sometimes.
We all need help.
Right?
Oh yeah.
A Sioux Falls woman asks, is there a relationship between dreams and how well you sleep? Dreams. Quickly now, we got a bunch of questions.
Oh sure, and it's a wonderful topic to really get into, but certainly REM sleep is where we think most dreams happen, and the complicated dreams, and waking up right after that REM sleep is where you remember your dreams. But really, if there's not a lot of time is needed, and you'll forget your dream after REM if you go back into a different stage of sleep. So if you don't ever dream and say, well, I'm not getting any REM, that might not be true. You just might not remember it. So
I started dreaming after I retired, or semi-retired, and got a little bit more sleep, because I was always cutting my sleep off, and I wouldn't have dreams. But the alpha sleep, the deep, deep, deep sleep, that's a weird dream thing, kind of a
delta wave sleep.
Yeah, delta sleep. But we got to move on.
Okay.
One viewer wonders if nasal allergies lead to asthma.
I think any upper airway obstruction. So in kids, it's tonsils, adenoids that are big. And if you have nasal obstruction, you're not going to get good flow. Usually you could open your mouth. But there actually has been something that came out recently, maybe recently, either way. But when people's sinus disease is treated, they have less snoring and sleep apnea, and so it does play a role. Rare, 90-something% the obstructions in the neck.
Get your allergies treated if they're a problem. That's why we have allergists.
Oh, yeah.
We had a question about claustrophobia and CPAP machine. A quick answer to that. Any comments?
I have patients, make sure they don't have underlying anxiety, so they talk to their doctor and make sure they don't have something that needs to be treated. But it is, not a natural way of treating a disease. I have people wear the mask when they're watching TV or doing something enjoyable.
So they can get used to it.
They get used to it. Yep. And then that helps with the anxiety. It feels more natural when you do go lay down in bed and hook the hose up.
So we talked earlier about benzodiazepines. Ambien is one of the major sleep aids that is basically Valium-like. And we really all agreed, try to avoid it if you can, not get used to it. It's really hard to get off because you stop it, you have withdrawal, sleeplessness. A peer woman asked, can you talk about cough variant asthma and how is it connected with nasal polyps?
Well, so cough variant asthma is one of the forms of asthma where the main symptom is cough. A lot of times that can be treated with a medicine called Singulair or even just as needed albuterol. You don't always need a steroid. And so as far as nasal polyps, there are different associations between allergies, asthma, nasal polyps, things like that. There's something called Samter's triad, where you'll develop asthma, nasal polyps, and aspirin sensitivity. Right. And so that can be treated with aspirin desensitization. That's another topic. But and so if you have nasal polyps, there may be an allergic underlying component.
Yeah. Look at asthma. Yeah. Look at aspirin as a possibility. Yeah. From Vermilion, a woman's wondering if you can talk about alpha-1 antitrypsin deficiency.
Yeah, well,
very quickly.
Yeah, that's a genetic disease, and if you're deficient in that enzyme, you have a higher risk of emphysema and liver disease. If you smoke, obviously that risk goes up. And
now there's a treatment that's hugely expensive and hasn't been scientifically proven to make a difference, right?
Yeah, it is expensive, and because of that, we offer free testing in the clinic through the company.
Oh, yeah. Yeah, the company paid for the testing.
Yeah, they pay for the testing.
But do we know that it makes a difference?
Well,
I mean, that's the question.
Yeah, I think it's thought to slow down the progression.
Thought to.
Yeah, and so, we in our clinic we use very strict guidelines on who needs treatment. Yeah. So.
Lennoxman asks, what are the effects of vaping on the lungs? You have a comment about vaping?
I think I'll leave this one.
Actually, vaping causes seizures, doesn't it? I just read this. There's a bad batch of vape pens in New York, and kids were having seizures.
It's not recommended.
Not recommended. No, it may cause an inflammatory lung disease called hypersensitivity pneumonitis. Can cause chronic bronchitis. Not proven.
Better than smoking cigarettes, though.
I don't know. We can't say that yet. You would assume so. Common sense would say probably better, but it's not.
It's not been proven.
Can't recommend doing that.
A man from Delmont has severe sleep apnea. Cpap leaks sometimes. He's tried to fix this, but has not found an effective solution. What can be done? Jeff.
Well, I look at that and I say make sure he's cleaning his Cpap and he's not building up oil on his mask. That's kind of letting go of the friction that's needed in the mask, and then. Maybe he's undertreated if the airway is closing, and then he'll have what looks like leaking because there's nowhere for the air to go. Maybe he needs another sleep study.
Maybe he can use one of the jaw devices. Yeah. But to talk to your device guy and your sleep study guy.
That's the key. Is the Holm Medical Company? They have all the variety of masks. They know more about the mask than the doctor prescribing the machine.
Yes.
Yeah. And you go in for a fitting, you keep calling them, you keep going in and stay on top of it. And if you run out of their masks, then the company next door has different masks for you to try.
We can try those things.
Yeah.
And now for the winner of tonight's Prairie Doc quiz question. Chronic obstructive pulmonary disease, or COPD, emphysema, and chronic bronchitis are all A, restrictive airway diseases, or B, obstructive? And the answer is B, obstructive airway disease. It was Mary Shortbull from Kadoka who answered the question correctly. Mary, congratulations. Thank you for participating. A book will be in the mail to you soon. We'll be right back after this.
Welcome to your Prairie Doc Library at www.prairiedoc.org. Wherever you live or travel, you and your family can enjoy free and easy access 24 hours a day. Search for a specific topic. Browse through the television shows, radio programs, and blog page. You, your family, and friends around the world can learn from physicians and other health professionals answering questions on a variety of medical topics. Visit your Prairie Doc Library today at www.prairiedoc.org.
Mr. S had gained some weight. His wife noted his snoring was getting worse, and he was having spells when he would stop breathing during sleep, or apnea. She informed his doctor, who prescribed a home overnight oximetry test. This showed oxygen levels were dropping dangerously low during much of Mr. S's night. The subsequent full sleep study indicated he would benefit from a continuous positive airway pressure, or Cpap device. 5 years later, the patient died from a heart attack, and the doctor found out that the Cpap machine stayed under his bed and was rarely, if ever, used. One study showed, despite its benefits, only 30% of those who are prescribed Cpap will actually use it. An estimated 22 million Americans suffer from sleep apnea, and the majority don't know they have it. Their sleep is interrupted by snoring, choking, and prolonged spells of low oxygen levels. Their days are troubled by fatigue, sleepiness, often abnormal heart rhythms, and heart failure. Their risk of stroke over 5 years is 2 to 3 times higher than usual, and risk of all-cause premature death 3 to 5 times higher. One estimate is that 38,000 annual deaths in the U.S. will occur from heart disease due to untreated sleep apnea. Making the diagnosis is challenging. In 2016, we gave a standardized questionnaire to screen for sleep apnea to 67 people who were 70 years old or older. Following that, we tested all 67 with home overnight oximetry testing. Of the 67 tested, 42% were normal, 31% had mild sleep apnea, and 26% had moderate to severe sleep apnea. Conclusions from my study were that in this older age group, the commonly used screening questionnaires for sleep apnea misses the diagnosis half the time. About 1 in 4 have life-threatening sleep apnea, and in this older population, women and men are equally burdened by this condition. Anyone with heart disease, high blood pressure, obesity, a history of heavy snoring or observed spells of apnea, and maybe anyone reaching 70, would benefit from a home overnight oximetry test, and if this test is abnormal, from a full sleep study. If Cpap is prescribed, it would be wise for that individual to make every effort to use the Cpap device, knowing that this non-medicinal therapy reduces death rate by 3 to 5 times. Many premature deaths, especially from heart disease, could be prevented by first discovering the diagnosis of sleep apnea, and then, when apropos, by taking the Cpap cure. Well, a big thank you to our guests for volunteering to join us in our studio on the campus of South Dakota State University. There were many great questions we were not able to get to during our broadcast time. We will continue to answer those questions on our Facebook page following the program tonight. Go to Prairie Doc Facebook page, and we'll be there shortly, right after this broadcast ends. This additional segment will also be posted on our website, prairiedoc.org, in the coming days. The flu season is winding down, but it was a serious one. Almost 10,000 cases and 39 deaths in South Dakota alone. Vaccinations do work, whatever the diseases they may be fighting. Be sure that you and your family are up to date on your recommended vaccines. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
Pain can ruin your life, but so can some of the treatment options. Are there new approaches to reducing pain or even eliminating it? A different approach to pain. Next time, On Call with the Prairie Doc.
Useful, scientific-based medical information delivered in a respectful and compassionate manner. This is what we get from the Prairie Docs. I am proud to serve on the board of the Healing Words Foundation. Our nonprofit organization works behind the scenes building financial support to continue and expand Prairie Doc programs. We thank the many health providers who volunteer their time to answer our health questions. Significant funding is required to produce and distribute video, radio, and print throughout the region. Your donations will help the foundation continue to offer free and easy access to the entire library of Prairie Doc health education programs. I grew up with Rick Holm on the prairies in DeSmet. On behalf of the Healing Words Foundation,
And on behalf of a lifelong friend,
we invite you to join our mission. Go to prairiedoc.org and click the donate button today. Thank you.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
and with the ongoing support of these individuals and institutions, the Brookings Health System,
Ophthalmology Limited,
Avera Heart Hospital,
Dakota Allergy and Asthma,
Fishback Financial Corporation,
Vance Thompson Vision,
Neurology Specialists,
Brown Clinic,
American Academy of Family Physicians Foundation and South Dakota Academy of Family Physicians,
Black Hills Medical Society,
Aberdeen District Medical Society,
the 3rd District Medical Society,
the 7th District Medical Society,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
Aberdeen Asthma and Allergy.
and Swiftel Communications.
Splendid.